Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sarjan, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. or register for the same. Online dentistry has been the pioneers in providing dental education via online and both offline sessions. It has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 203 offline courses and have conducted 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Biduti Abraham. He's one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Alva. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter is currently the HOD of Department of Pediatric Dentistry at Anu Dental College and Hospital. Over the years, we have grown dynamically, launching 10 centers in different parts of India. On popular demand, we are relaunching our next 3-day session on March 22nd, 23rd, and 24th at Cochin. We are open for fresh registrations via our website. The latest addition to our courses, the 1-year comprehensive advanced master training program on interceptive and myofunctional orthodontics, have been successfully initiated with 2 batches. This is a multidisciplinary approach with intense training and hands-on session. The program is now a fellowship program on interceptive and myofunctional orthodontics, which is accredited by the Manipal University College, Malaysia, which is also a sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with the graduation ceremony and certificate distribution as well. Right now, we are a batch full. You can always feel free to reach to us on our WhatsApp number or visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for 14 years past. During the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. And in the year 2023, we are relaunching the same by providing free advanced learning CDs under the title Online Dentistry at 9 p.m. So without further ado, let me move on to introducing the speaker for the day, Professor Dr. Srikant. He served as the coordinator for Center for Forensic Odontology, Manipal College of Dental Science, Mangalore. He is currently pursuing his PhD at the Manipal Academy of Higher Education. He has authored and co-authored 7 textbooks covering a wide range of oral and maxillofacial pathology and dental anatomy and histology as well. He has many highly indexed research publications, Best Research Award, Best Presentation Award, Best Teacher Award, and Technology Innovation Award to his credit. Proudly welcoming Sir to the session. Sir, the session is all yours now.
Thank you, Anita.
Thank you, sir.
I'll go ahead with, yes, thank you. I'll go ahead sharing my screen.
Yes, sir.
Yeah, a little feedback. Is it visible? The full screen should be visible now.
Sir, yes, sir. Right now. Yes, sir. Perfect.
Good.
Yes, sir. We are good to go.
All right. So good evening to one and all here. I hear that the majority of the participants would be private practitioners. So I am an oral pathologist by profession and have various interests in understanding the disease from a pathologist's point of view. So my job here is to help all of us make our jobs easier by understanding the crucial role that a pathologist play in a dental clinic and what are the different ways in which we can improve the diagnosis and maybe the treatment in future. So my whole talk would be under the 5 basic headings like this. The first component we'll be talking about is the biopsy procedure itself. So the first and the second one would deal with what is the strategy that you should follow to do a biopsy? What are the precise biopsy procedures that you would uh, follow? What are the expectations from a pathologist? So at the end of this talk, you should be able to identify at least four pathological foundations of the chairside tools and which you will be commonly using. And then, of course, you might have encountered a lot of reports that come to you from a pathologist. So I will talk a little about decoding the pathology, understanding it better, and also finally, as a part of the dental practice, how important is meticulous dental record management. So going on to the first heading, the strategic biopsy timing. So we have every now and then would have seen a few group of cases or patients when we are in a dilemma whether to uh, have a look at whether to go ahead with a biopsy or we don't go for a biopsy. So usually when a lesion is growing or has been consistently there for 2 weeks, that's what we call it as the 2 week rule. So if you see that there is consistently a presence of an ulcer for 2 weeks, a swelling for 2 weeks, you have tried out some procedures, maybe you have given antibiotics, you have curated the area, you have given mouthwashes, etc., but it has not come down, then it's a golden rule that you go ahead and biopsy the lesion and identify what it is. It may be as simple as a small abscess, or it may be as critical as a carcinoma. So it's better to go ahead and do a biopsy when it's not healed for more than 2 weeks. But you should be careful about the various anatomical considerations. You should be careful about maybe the anatomical location. Maybe is there a bone involved? Is there a blood vessel involved? So you need to be aware of the basic anatomy in a particular region. Say, for example, the posterior part of the tongue may have the lingual tonsils. It may be a normal growth because of some infections or throat, etc. So that cannot be considered as a chronic lesion. But however, if you have an ulcer which is painless, then it triggers a question mark as to whether you should do a biopsy or not. There may be some technical considerations also, especially when it comes to vascular lesions. You cannot always do a biopsy for a vascular lesion. Obviously, in a dental clinic, if there's a highly vascular lesion, you may face some trouble in restricting the flow of blood after the incision has been made. So uh, we should be careful and we should be capable of identifying vascular lesions before you put a knife to it. That's one of the major reasons why most of the biopsies of vascular lesions are done in a hospital setup rather than in a dental clinic. So there are some techniques with using which you can identify a vascular lesion. So we'll talk about that in a forthcoming slides. We also need to be careful about bone, which is slightly weaker than normal. So in a healthy bone, you usually have a very good blood supply. We have very good cellularity in it. And this will allow the bone to interact, rather the bone cells to interact. And they talk to each other and they decide whether they should continue to modulate the environment in that region or not. This is compromised in certain cases. For example, in osteomyelitis and osteoradionecrosis. Now, osteomyelitis can be bacterial, can be associated with trauma, it can be maybe fungal osteomyelitis. Whatever be the case, the bone is dead. There are no cells within, so that whole area cannot modulate. Now, you will remember the various cells that are a component of the bone. The outside of the bone is covered by osteoblasts. The inside of the bone is having some trapped osteoblasts, which are called as the osteocytes. They are all connected by tiny trabeculae, tiny canaliculi. They talk to each other. So that is not there in these two conditions. The bone doesn't heal. So we need to be a little careful with that. Another important and interesting condition would be something which is pigmented. So usually we have the epithelium, and on the base of the epithelium, you will have these melanocytes sitting. And these melanocytes are usually quite far away from each other. And they tend to fall into the connective tissue in certain conditions, which we usually see as nevus. And when this particular cell becomes malignant, they start growing in a horizontal direction. Now, suppose you want to identify what that lesion is and you give an incision and you take out a piece of tissue from that area. What you have done is you have actually given a pathway for the cells which are already freely floating inside the connective tissue to go deeper. So your horizontally growing lesion starts to develop downward and you get a vertically growing lesion, which is not a good sign. So we have a classic clinical method, which we call it as ABCDE. A stands for asymmetry, B stands for border irregularity, C stands for color change, D is the diameter, E is the elevation. So when we look at a pigmented lesion, we are really very careful about it, and we do not go for a biopsy. Other than these, hardly there is any contraindication for a biopsy procedure, which you may encounter in a private practice. Then you have some special considerations about potentially malignant disorders, which I'm sure in an Indian context will be relevant because there is abundance of habits of tobacco, the areca, etc., smoking, and these leads to not a single unified lesion, rather a continuum of multiple sites being involved, and it may pose a trouble for the clinician to identify where do I take the biopsy from. So we will discuss that in the upcoming slides. So let's start with the first idea of what exactly are the biopsy procedures. There are two main groups of biopsies. One is called an incisional biopsy, another is called an excisional biopsy. If a lesion is very large, if let's say that you have a whole of the buccal mucosa involved, or maybe one lateral half of the tongue being involved, then obviously you cannot cut out the whole area without identifying the lesion. It can be a lesion which can be treated without extensive damage to that area. So it's always preferable to have an incisional biopsy. So incisional biopsy is done when you have a very large lesion. But suppose the lesion is quite small and you are able to remove the lesion in toto. That's called as an excisional biopsy, and it serves as a treatment also. The incisional biopsies can be done in various ways. I'm sure you are aware of a wedge-shaped biopsy can be done, or you can have a punch biopsy where you have various diameter punch uh, tubes that are available, and you can actually poke through the skin, then lift it up and incise it. So let's look at some considerations in this case. So punch biopsy is good in certain sites where you have sufficient depth. But when you are looking for a palate or somewhere where the mucosa is very closely adherent to the bone, punch may not be a very useful tool there. And you need to be very careful because there may be a blood vessel going through or a nerve very close to the surface of the mucosa, especially in the lower third molar region. So we need to be careful about where we use the punch. And that's where knowledge of anatomy plays an important role. And when it comes to using a scalpel, it's always better for me to have a thin, deep biopsy rather than a large, shallow biopsy. And why I would say that is, let's say that you have an epithelium which has a very nice growing kind of rete. So they are pretty deep, right? So if I take a shallow biopsy, I will be taking a biopsy only of this area. I won't know what is happening underneath the epithelium in this region. So if you had given us a biopsy which is pretty deep, but if it's narrow also, it's fine, then we will be able to diagnose more accurately. So we need to understand a couple of things over here. When you are doing an incisional biopsy, we will be doing it when the lesion is very large and you need to sample certain sites. So you generally do not restrict yourself to a single biopsy. The same lesion may be a spectrum. From various sites, they may have different behaviors. So it's always better to have multiple sites being taken out rather than a single piece. So that's point number one. Point number two, whenever you're taking a biopsy, it's better to have a thin, deep biopsy rather than a shallow, narrow biopsy. So let's proceed with the next component. It's always the third element which I have written down here is the cytology. So what does cytology mean? Cytology is the study of individual cells. So can we see the cells in an incisional and excisional biopsy? Of course, yes, we do see cells, but they are in an architecture. That means they are arranged in the form of a tissue. So you will have the basal cells, suprabasal cells, etc. for the epithelium. You will have patterns of connective tissue, etc. But cytology is not like that. Cytology is something where you have two subheadings there. One is an exfoliative cytology where you can just scrape out the superficial epithelium and study it, or you can have something like a fluid, like a cyst or a blood. And it's never a bad idea to invest in a microscope. Now, earlier microscopes used to be really expensive. Now you do get reasonably priced microscopes. Under 10,000, you'll get a good microscope, and you have attachments for your smartphones that are also available. This is just a Google screenshot, may not be relevant, but yes, what I would like to say is there's no harm in learning how something looks like under a microscope. For example, on the bottom left, you can see something which looks very crystalline. This is a cholesterol crystal. And cholesterol crystals are very common in inflammatory cysts. Now, you may have a periapical lesion and it's very large, and you are just putting a needle there, sucking in the fluid, and you're putting it under a microscope and looking at it, and you find a lot of these crystals. You can at least tell that it's an inflammatory fluid. But it doesn't mean that other cysts do not have this kind of changes, but at least gives you an idea. If you find it lot of cellularity, lot of keratin in it, you can also think that it may be an odontogenic keratocyst. So it gives you an idea, but obviously it's not confirmatory, but it gives you an idea. In the second picture here is a blood. So if you have a lot of fluids that is reddish in color, you may have a doubt whether it's blood or something else or a pus. You can actually get a hint instantaneously, chair side itself. And if you do find some organism sitting there, you can go ahead and uh, uh, prescribe a different set of antibiotics, or you can plan it out like that. So it's never too late to learn about cytology. Uh, as a chairside tool, it's a very useful element in a dental clinic. So going ahead, now I told you that there's a biopsy and a cytology. So you may ask, cytology, I can do it myself. Why should I depend? But always biopsy is superior. There are multiple reasons for biopsy being superior to cytology. Now, cytology is something very superficial. You are not seeing the lesion per se. You're not seeing the changes in the baseline, that is the connective tissue, epithelium, etc. So you need to look at the tissue as a whole. That is, you need to look at the layers. You need to look at the changes that are taking place. So you need to understand that biopsy is superior. And like I said a couple of slides back, a deep biopsy is definitely better because I need to see the depth of that particular uh, uh, lesion. And punch biopsy is suitable when the area is firm and you can go sufficient depth, but you need to be careful. You need to understand the anatomy properly. Cytology is very much a good tool for a screening, so you can do it both ways. You can have a look at it under the microscope immediately and console the patient. This is what I think. Let's have a look at it. Let's give it for the biopsy procedure. Let the pathologist have a look at it. We'll confirm it. Sometimes you may want to see the culture sensitivity. If you're looking at a long-standing swelling of a lymph node, maybe on the neck or something, which is pretty sure an infection and has not subsided with multiple antibiotic therapy, you may want to give it for a culture sensitivity. And there does exist amount of protein analysis, however, not very useful, not superior to the biopsy procedure as such, but it does help us in identifying and narrowing down the lesion to a great extent. So let's proceed with what next? What next? So whenever you finish a biopsy, so you have done the biopsy, you have either done an incisional, excisional, or a cytology. What do you do next? You need to give the pathologist and requisition form. So we usually get requisition forms like this. We get something like send it to this person, this is the name of the patient, this is the age of the patient, etc. So we want a good clinical detail. We want a good clinical detail, and we need habit history. We need radiographs. Pathologists are not magicians. We cannot look at the slide and have a look, understand, this is the lesion. No, it's not possible. So if a biopsy comes with a good history, it will reduce the diagnostic dilemma. So I would like to show you these two pictures. And any pathologists over here? I mean, are you allowed to talk? Uh, Anita, they can interact maybe? Are they allowed to interact in the group?
Sure, sir.
Yeah.
If anybody raises the hand, we can definitely unmute them.
Yes. Can anyone tell me what they are looking at, or what is this? Do you think these two are different, or they are the same? They look the same? Can anyone point out uh, what is this snake-like structure here? What is this? Can anyone tell me what I'm drawing this here? Anyone? Nobody? So
I think
see,
they're pretty much confused.
sorry, yes, please continue.
So I think they're pretty much confused. We're not receiving chats. That's it.
Okay, no issues. So here, if you look at it,
Yes, sir.
we see some cyst over here. Oh, there's a chat.
So
Someone is
we have,
coming.
yes,
Yeah,
sir,
very good.
Dr. Christina, epithelium.
Yeah, correct, Christina. So you do see an epithelium over here. So I'm happy you responded there. Thank you. Here we have epithelium on both the sides, and inside the center you have a lot of keratin sitting over there. So they look pretty much alike. They look like cysts. They have an epithelium which is keratinized. They have pretty much good connective tissue present in that region. Very good. Christina is even saying it's an odontogenic keratocyst. So let me ask, continue to ask, do you think both of this is a odontogenic keratocyst? Should be a yes or a no. Let's see.
No, sir. That's
Why
what
not?
says
Why
not.
not? Yeah, that's exactly. So you see, when we look at a slide like this, we may get pathologists also get confused. They do look both like an odontogenic keratocyst, but in reality, what if I say that the left lesion came from the bone and the right lesion came from the finger? They look alike, right? So we need to be very, very careful. The left lesion is actually an odontogenic keratocyst. Kudos to Christina there answering that left one, right? But there's a very similar lesion called as the epidermoid cyst, which uh, there are ways in which you can identify it. But however, in the first glance, it looks very much similar, and that could have been very easy to identify if you had given a complete history, something like this. So look at this completely filled document telling us what is the habit like, where was the lesion, how big is it, what do I think the clinical diagnosis is, where are the locations, how much is the size. So it saves us a lot of trouble. So please do take some time out to fill the requisition form with good clinical details, habit history, radiographs, and all the relevant information. Even if you feel it's not relevant, it may make sense at some level of diagnosis when the diagnosis is not easy. So it will save us a lot of diagnostic dilemma. And like many pathologists say, lesions don't read textbooks. So one lesion looks like the other in certain conditions. So it becomes very difficult in certain cases. We ourselves sit together, discuss, read books again and again to identify certain difficult cases. So it helps a lot when you give us the radiographs, when you give us the clinical pictures, brief history, a quick interaction, a voice message. Now WhatsApp is there. You have communities which can be used to dissipate the information. So once I get the point clear, you know what biopsy you're doing. You know that you have to give the clinical history so that it prevents us to do the diagnostic dilemma. Then the next important point I would like to emphasize is handling the biopsy. Always give in a good fixative. What does fixative mean? Now, when you have a small tissue, let's say that you have a soft tissue, as soon as you excise it, it is very, very soft. So it's like pliable. You can actually move it. Now you dump it in this 10% neutral buffered formalin. It actually cross-links the uh, proteins there. So it actually cross-links the protein and it becomes very, very hard. So why do you need to make it hard? Now, you need to make it hard so that it doesn't undergo necrosis. Now, what is necrosis? Necrosis is nothing but death of a tissue. Now, death of a tissue is not a good thing for the pathologist because once a tissue dies, we have lost the cellular architecture. When we can't see the cell, we don't know what it is. When we can't identify epithelium and connective tissue, we can't diagnose it. So it becomes impossible for a pathologist to diagnose when the fixative is not proper. Now, let's imagine that you have an LA bottle and you put this inside an LA bottle, right? Now, LA bottle has a narrow mouth, correct? And you have dumped it inside a nice amount of formalin there, and it's in a fixative. It's going to become hard, right? So it's going to become hard. Do you think I can take it out from this narrow bottle? No, obviously not, because it's become hard now. When you pushed it in, it was soft and pliable. But I will have to break it open when in my lab to actually take out the tissue, which may, if the tissue was really big, it may harm the tissue. There may be glass fragments getting stuck in the tissue, which may be diagnostic. So please always keep in your clinic a certain amount of wide mouth bottle. So dental clinics are have abundant supply of the cement bottles, GIC bottles, etc. So take some care in giving us the Uricol bottle or a wide mouthed cement bottles, which will be useful. And narrow mouth bottles will not be very good. So a common question that I get is, मेरे पास formalin नहीं है, what do I do? So there are a certain group of studies that are available. What is a good transport media? Definitely not an LA or a saline. And my next best preferred solution would be any form of an alcohol. So if you have a cytology fixative, okay, well and good. Otherwise, you have ethanol, you have spirit. It is an alternative. It's not a very good alternative, but it is an alternative just to preserve till it reaches the laboratory. If you feel you're doing a biopsy maybe in the evening and you're going to send it across next day to the laboratory, if you have a 1 day delay there, it will sustain in an alcohol better than local anesthesia or a saline for sure. But there are some studies in which you can use honey, jaggery, sugar solutions, anything that can preserve the tissue. Uh, but personally, we have used some sugar solutions and it hardens. The sugar actually hardens and precipitates on the tissue. It may trouble it. So preferably, we would like you to keep a stock of 10% neutral buffered formalin. It's very easy to make. You get the formalin in a bottle, you dilute 1:10. That is 1 ml of this. Or if you have a small bottle, if it's not 10%, it becomes 11 or 12%. It doesn't matter much. But formalin is formalin. It's always better to use 10% neutral buffered formalin. The buffering is actually a method in which the phosphate buffer is used in the formalin uh, so that the formalin doesn't precipitate, it doesn't become acidic, damaging the tissue in certain elements like when you need to do immunohistochemical staining, etc. However, if you're transporting it within 30 minutes, it's quick and easy, it's nice. Immediately you can put it in a bottle, put alcohol, send it to the lab. The lab will immediately transfer it to neutral buffered formalin. All right. So what do you expect? So you have sent us the biopsy. What are your expectations? So you need to understand certain things about the laboratory. So know your laboratory, the style of processing. Automatic tissue processors usually take 1 to 2 days to process the tissue. And then you have another day plus 1 day for the technician to take sections and give you the slides. And usually 3 to 4 days for an a lab which will have automatic tissue processors. But if you have a manual tissue processing unit there, add 1 day to it. So you will usually take 5 days. And the availability of the pathologist, you should expect the result in 5 to 6 days. So generally, our turnaround time is around 5 days in our laboratory. Whenever we give biopsy, usually by the time the suture removal happens, the reports are usually ready. But you should understand that there may be certain conditions in which I would like to do something more with the tissue, like take extra sections, do some special stains to identify certain special components, like special type of connective tissue, special type of organism, bone, how deep it is, and something like that. And maybe we also don't know what it is. We want to go for a consultation. So you can extend it up to the 10 days if the diagnosis becomes difficult. So always better to talk to the pathologist and say, hi, what happened? So we may give you a quick insight. Yeah, it's coming today, it's coming tomorrow. And it's nice to talk to the pathologist directly. That's what you should expect when a soft tissue is given. But hard tissue is a different ball game. Now, we have machines called as microtomes. We have a block which cuts, and that cutting is something like a normal blade. If it's a soft tissue, you can cut it through. But if it's a hard tissue like a bone or a tooth, you cannot cut through it. So you need to decalcify it. And decalcification of the bone usually take 10 to 15 days. Tooth takes longer. As you know, enamel is the strongest and hardest tissue. It takes 20 days. So when you're looking at a decalcification tissue, the size of the tissue matters a lot. You give a segmented maxilla or something, it is going to take longer than a single tooth or a small piece of bone biopsy. So size matters, and the type of tissue, that is whether it is tooth or bone, also will be affecting the whole concept. So in general, I have given you a very good insight as to what are the different procedures, what do you have to accompany it, that is the requisition forms, and how the clinical details should be given. Handling, you need to have an understanding of what happens into the tissue when the tissue has been cut from the patient's mouth and put in the formalin, and expectations in brief. So these were the first two headings of my talk. Quickly going to the pathological foundations of chairside tools. In quick succession, let's have a look at the first one, the pulp vitality tests. All of us have done pulp vitality tests. What does it do? It tests whether the tooth is alive or not. But vitality is in reality vascularity, right? But is heat, cold, and electric pulp testing checking the vessels vascularity? No, it's not. It's appropriate to call it as a pulp sensitivity test. And you are definitely aware that when you touch the affected tooth with heat, cold, or electric testing, the pain persists, then it's irreversible. If the pain subsides, it's reversible. And if there is no pain, it is necrosis. But what is the logic behind all of this? So we need to be concerned about certain things here. So you must have seen many of these jalebi and vada pav makers. They actually pick up. Look at this guy picking up a hot fried item with his bare hands and just taking it and putting it. Doesn't it has hand uh, uh, hurt? So yes, it does. It does. So we need to understand that the timing matters a lot. This is the phenomenon of lead-in frost. What exactly happens is there is an insulating layer of carbon dioxide or freon, whatever you're using for your heat or cold test, which forms a coating on the surface, which prevents the tooth to be damaged. But if you continue to give heat or cold, it can go to plus or minus 78 degrees, which is going to be harmful for the mucosa and the enamel and can crack. EPT, on the other hand, has a problem. Be careful about any electronic devices that a patient is using, like the cardiac pacemaker. You do have artificial insulin injectors and other electronic devices. You need to be aware of it before doing such tests. You need to be concerned about it. So what exactly is this then? What is pulp vitality tests? There are other vitality tests which actually check for the vessels. Uh, the vessels can be checked by transillumination, like you see in the first picture. And you can also have something called as pulse oximetry or photoplethysmography. So in your mobile phone, you can actually access an app called as ECA. And this app actually looks at, if you're looking at my finger, I'm just placing my finger next to the uh, camera here, and it is actually measuring my, you can see a red patch over there, and it's actually measuring my heart rate. What is this? This is the method of photoplethysmography, and it has been used by many to check the vascularity. And one Japanese article, which I'm quoting over here, has tried the photoplethysmography to actually check vitality. You should understand that it exists, and maybe you can explore the possibilities of using this to be more accurate. The potentially malignant disorders, on the other hand, have some changes, which you can see. You can see that the lesion is pretty big. Look at the lesion. Look at, you have the ebbing tide pattern. So you can have a bottle of toluidine blue, right? So here you have a bottle of 1% toluidine blue. Okay. The patient is asked to rinse the mouth, then put you up, you dab toluidine blue, and you can see that the blue is taken up in certain areas it is not taken up. So what is this? The DNA, which is proliferating in a potentially malignant disorder, it gets bound to this particular dye, and it tells you that this is the area which is more proliferative. So we will take a few biopsies from these areas. So like I said, sampling is very, very, very important. Floor of the mouth is more dangerous. Take biopsy samples better from these areas, and then you can go ahead. When you go to another common technique called as the Wellscope or Visilight, what does it do? It actually checks for the biofluorescence. The normal epithelium and the connective tissue has fluorescence. That means it emits a green light. When a blue light goes, it emits a green light. So this principle of biofluorescence disappears when there is abnormality. So here you can see that there is disappearance of fluorescence, which will give rise to potentially malignant disease change happening in this particular area. So you may want to take a biopsy from these sites. So very good use uh, in a clinic overall. Then something similar happens with a disease called Frey's syndrome. It's not potentially malignant, but I'm bringing this because I'm using iodine over here. Because of a trauma, the patient has a faulty innervation of the auriculotemporal nerve, and he starts sweating whenever he uh, eats. So this area, when you put starch in on the face, you can see that the iodine reacts with the starch when water, that is the sweat, comes out and it becomes blue. Similar principle can be used inside the oral cavity. When the epithelium, which is there on top here, is proliferating, right? It's proliferating a lot. It is using up all the stored glycogen. There's no starch available. So when you actually apply toluidine blue, this area, the area where the activity is very high, the glycogen is no longer there. So when there's no glycogen, it becomes pale. So these are the areas where you should take biopsy from. And Lugol's iodine is easily available. You can actually buy a bottle and keep it, and you should understand the principle so that you can use it. Another common thing that you can face, and it's easy to diagnose, is fungal infection. You may have a doubt whether it is candidiasis. Red lesions are multiple. You can have erythroplakia, you can have candidiasis, you can have lichen planus. You can even think of desquamative gingivitis in the form of genodermatosis like pemphigus, pemphigoid, etc. But at least you can rule out fungus. You can keep a bottle of KOH stain, take a small smear. Here I'm showing you a photograph of a gingival lesion picked up from the probe. You can put it on the slide, put some KOH. The KOH, what it does is it destroys all the epithelium and the background, and it projects the fungus more prominently. So you can actually visualize the fungus, and you can diagnose it quickly. And at least you can give a mouthwash and see if it heals within a week or 10 days, then decide whether to take a biopsy or not. So our chairside tool of KOH will be useful in your clinic. As promised, vascular lesions are important to not to biopsy. So if you're looking at a vascular lesion, right, you can take a small slide, keep a box of slides in your clinic, you press it against the lesion. When you press against the lesion, what you are doing is you're pushing the blood back through the blood vessels. So the lesion becomes pale. And you can do this in the tongue, buccal mucosa, lips, very useful. If it doesn't fade away, then you know that it's something else, some kind of pigmentation or some kind of a long-standing lesion. You can accordingly do a biopsy if required. So diascopy, useful tool to identify vascular lesions. Going on to the second last segment, the decoding of the pathology report. So here I have a patient report. So usually the demographics comes as the clinician would have sent to us. And then on the bottom, you will have a small description of the gross. What does gross mean? How it looked like in the bottle which you sent me, how it looked like. Why do I need to do? So you might have thought that I sent you a biopsy this big. Let's say that I sent you a 1 centimeter big biopsy. Now this 1 centimeter big biopsy goes through formalin, then it goes through alcohol, then goes through xylene, then goes through wax. And finally, when it actually comes, it's actually 30% smaller. This is the actual size of the particular biopsy. So you did send me a 2 centimeter biopsy, but in reality, I am looking at something of 1 centimeter, right? So we need to be careful about, we need to keep a record of what's happening with the tissue. And also we do look at the color, the texture, the shape, the extent, etc., which gives us a lot of hint for what kind of lesion it is. Then we write the microscopic report. Now, in the microscopic report, you should understand what kind of lesion is it? Is it predominantly an epithelial lesion? Is it predominantly a good lesion or a bad lesion? And then finally, we have 3 headings that are written. So here is the first heading. So here the first heading says suggestive of. So what does that mean? So let's have a look at it. Now here is a biopsy requisition form which has come to us with a heading with a provisional diagnosis of osteomyelitis. But when I looked at under the microscope as a pathologist, I was not able to find something related to osteomyelitis. I am thinking it is more related to another lesion called a central giant cell granuloma. So when I am, you are saying something, but I am getting something else. There is a mismatch. We generally write it as suggestive of. And usually we would suggest some extra elements that would be useful to identify, like a postscript. But when it comes to compatible with, it's quite clear cut. So you will get a diagnosis of compatible with where the provisional diagnosis of the clinician matches with the histopathologist. But you need to be sure that we could not have diagnosed without your clinical information. So there are so many lesions which look like a dental follicle, but just because you told that it is attached to the crown of the tooth, I am giving a diagnosis of dental follicle. It couldn't have been possible without you, the clinician. So when I say compatible with, I'm agreeing with you. Because you gave a clinical history, I was able to give a diagnosis. If you hadn't given the clinical history, I wouldn't have given a diagnosis as such. The third one is clear-cut indicative of. So it's so clear that whether with or without the clinician's report, this is what it means. And obviously, we arrived at it because of the extensive help that the clinician has given us in the form of the history, etc. But stand alone, if another one person is looking at this slide, he is 100% sure that it is the particular lesion. So that these are the 3 headings that I would like to get across. The last part, I have already touched 45 minutes of the time. I am going to end this with the last bit of meticulous record keeping. Now, there are a lot of softwares that are available in your clinic. If you do not have a software, at least have a habit of recording it and digitizing it. You may write a a sheet of paper or a prescription, record it nicely, take a picture and save it. It always helps. There are multiple ethics and medical legal issues that it helps. Last but not the least, not very prominent in Indian setup, but yes, over the years, we have encountered a lot of cases of forensic identification, comparative dental identification, disaster victim identification, where a missing persons report has been used. In our setup, we do run a center for forensic odontology, and we have helped in certain ways of identifying the age, sex, to a limited number of cases, but yes, we do. And as a dentist, as a BDS or an MDS graduate, even a BDS graduate is a specialist. He is a specialist who is capable of identifying human and animal tooth, who is capable of identifying deciduous and permanent tooth, who is capable of identifying bite marks of a human or an animal. So yes, you are all experts. Whatever is your qualification, as a dentist, you are an expert. There may be a day when it comes that you may want to be a part of a forensic investigation. It may be as simple as a civil case like age estimation for a sports event, under 17 sports event or something like that. We do run a certificate program in our college, and you can learn a lot of things about all of these in our center also. So in quick, thank you so much for online dentistry to given me the opportunity here. I hope I could convey the pathologist's view, how it can be useful for a dentist in a private practice. And you're free to contact me at the given email ID, and it's open for discussion. Anita? Yeah, over
Thank
to
you,
you.
sir. Thank you, sir, for the wonderful session. Now you guys can post your queries in the chat box. So from Dr. Rajivar, nice presentation, sir. We're waiting for queries from the chat box. So I think they've understood over more. Thank you, sir, for the session.
Yeah,
Thank you, sir,
okay.
for the session. And so stay tuned till the next punching session on next 4th Wednesday. Till then, bye. Stay tuned. Good night, sir. Good night, all.
Good night. Good night. Yeah, bye.